Wherever you get into trouble, you go back to the basics. Because if your basics are clear, then you can work things out. But if your basics are not clear, then you'll have to remember each and every fact. You can't work it out. Okay? No, whatever you do in critical care does not make anything better. Let me give you an example. If you don't put a patient on the vent, they might die. But that does not equal to, I put patient on the vent so they will live. Okay? If I don't give Levophed, patient will die. Doesn't mean that if I give Levophed, the patient will live. Because all you are trying to do in critical care is giving the minimal support necessary to maintain life while the patient recovers. Okay? So if you have septic shock and you have an infection, so source control and antibiotics, all the critical care guy is doing is the minimal support necessary to maintain life while these things get a chance to work. Okay? Shock being the main part of critical care. What defines shock? Anybody? What is the one thing that defines shock? Very good. It's not the blood pressure. Shock of any kind ultimately ends up in cellular hypoxemia. The inadequate delivery of tissues, oxygen to the tissues. So if you ask us, what does critical care do? We are the Amazon of delivering oxygen to tissues. Really, that's what we do. There was a study in 1998, I think in the critical care journal, you will see DO2, VO2 relationship. That study always comes up. You deliver enough oxygen, the people who can utilize the oxygen, increase their VO2 in response to your delivery, live. And the people who can't do that die. So whenever a patient is there in the ICU, the patient dies, I look at, did I optimize oxygen delivery? If I did, then it's not my fault. I sleep easy. Because I delivered the oxygen, the patient didn't use it. But if the answer to did I optimize my DO2, optimize, not maximize. And the answer is I could have done more, then essentially I could be responsible for the patient death. Same way, a lot of patients die every day in ICUs in the world because we try to normalize things in people who are very abnormal. You will see that with respiratory therapy most of the time. You will see that with nursing, and it is our job to tell them that no, the blood pressure does not need to be 120 by 80, and no, the oxygen does not need to be 94%. Okay? So what is the formula that we use to deliver oxygen? Simple thing, 98.5% of the oxygen that goes around in the circulation is attached to hemoglobin. Each hemoglobin gram takes about 1.34 ml of oxygen. And when you multiply that, that is your oxygen content. How much of it is saturated? So hemoglobin into 1.34 into saturation. And remember, when you do saturation, it is divided by 100. So 90% is 0.9 and 100% is 1. Okay. That is your oxygen content per deciliter of blood. And when you multiply this with cardiac output, you get oxygen delivery, DO2. Okay. So in a normal person, your DO2, in a normal person, your DO2 is equal to 15 grams per deciliter is your hemoglobin into 1.34, okay, into 100% saturation, which is 1, into cardiac output, which is 5. It comes to about 1005 ml of oxygen delivered per minute. Does that make sense how that works? Okay. Now we know that cardiac output is equal to stroke volume into heart rate. Very basic stuff. And stroke volume, we know, depends on preload, contractility, and afterload. Agreed? So now you have the formula, hemoglobin into 1.34 into saturation into stroke volume into heart rate. That is your delivery of oxygen. Do you have to remember this formula? Absolutely not. But a few things that you have to remember is saturation matters, not the PaO2. Because if you really look at the formula, there is an addition of 0.003 into PaO2. There is that addition there, which means that in a normal person with an oxygen content of 20.1 milliliter of oxygen per deciliter of blood, your PaO2, the dissolved oxygen in the plasma, only adds 0.3. Now, there are certain conditions. What if my hemoglobin is 3 and my cardiac output sucks? You would suddenly realize that the percentage of oxygen that is being carried dissolved in the plasma now becomes a higher percent. It never goes above 15 in real life. Even if you make the PaO2 from 100, which is sort of normal, 90 to 100, to 600, you will still not be able to deliver more than 1.2 ml oxygen per minute. Therefore, you can usually ignore that completely. It can be ignored. So the saturation matters. You don't have to do ABGs after ABGs to figure out what your PaO2, unless you have a doubt that the saturation you are looking at is not the real saturation. Okay. The formula tells me one thing, that if I have to change the oxygen delivery in my patient, I can only change a few things. I can change the hemoglobin, right? But there's a limit. What's the limit? And why? So the limit of hemoglobin, can I make your hemoglobin from 7 to 15? I guess I can. Should I? Why? Because first of all, it's somebody else's blood and it has been out of the body for some time. So what happens is that when this blood goes to the capillary, these RBCs don't, and I've seen it myself in a Russian guy's lab in Tulane, they don't flex. So they clog up the capillaries. They don't go where they are supposed to go. Plus, if you have 15 grams per deciliter of hemoglobin, that is mass. Who moves that mass? Your heart. What's wrong with your heart? Why are you in the ICU? Okay, because you are hemodynamically unstable. So now we are making a hemodynamically unstable person's heart move around a lot of hematocrit. Okay, that's weight. What about saturation? First of all, you can't make it more than 100%, right? But what about PaO2? Why can't I make the PaO2, 600? What's the problem? Because everything you do affects something else. And we'll talk about that saturation problem, but you can never make it more than 100. Preload, that is a whole different lecture. Okay? But that's why you give fluids. What you are trying to do is that if you give fluid boluses to anybody, you are trying to answer that question. You are trying to answer the question, if I give this bolus fluid to this patient, am I going to increase their cardiac output? Because if I give you fluid and I don't increase your cardiac output, where did the fluid go? Okay. Contractility, the reason that you are using dobutamine or you are using epinephrine. Afterload, I can manage that. Would you want to increase the afterload or decrease it in order to increase cardiac output? Yeah, usually you decrease it. Absolutely. Okay. And that is why if my blood pressure is 200 and I have a headache, it's not because my blood pressure is making my cardiac output high, it is making it low. My afterload is too much. And of course, heart. These are the only things that you can change to change the DO2. And everything you do affects something else. And we'll talk about that. Hemoglobin we talked about. It's an additional weight. Yes, if it is below 7, you would make it 7. Push comes to shove, I'm having a really bad problem with my patient's VO2. After I've done everything else, like Rivers et al., I could make it 9. It has never been shown that more than 9 is better. In fact, you'll harm something. Let's talk about saturation. Whenever somebody tells me that the patient's oxygen saturation is low, you have to ask why. Because if you don't know why, then how can you correct it? Okay? So there are 5 reasons why any human being's oxygen goes down. One is low ambient oxygen. I went on a Boeing 747 and the thing blew off. No, happens. There's no oxygen in the mask, you're done. Low ambient oxygen. On Mount Everest, no oxygen ran out. Low ambient oxygen. Never really happens. Blast happens, sucks out all the oxygen. Okay, Israel, Palestine, whatever. It doesn't happen in the hospital. P over Q less than 1. I have got ventilation, but I don't have perfusion. Okay. Sorry, I have perfusion, I don't have ventilation. So something is filling my alveoli so that the carbon dioxide in the blood is not coming into contact with the alveolar air, and the oxygen in the alveolar air is not coming into contact with the capillary to the transfer. Usually, you'll see this on an X-ray. Unless you have a intracardiac shunt, you will actually see this on the X-ray. Because what is filling the alveoli? Blood, alveolar hemorrhage, fluid, water, okay, pulmonary edema, mucus, atelectasis, protein, ARDS, pus, pneumonia, okay. When the V over Q is really bad in a shunt physiology, you know about it immediately because you increase the oxygen and nothing happens. You increase the FiO2 and the patient does not react. You decrease the FiO2, patient does not react. V over Q greater than 1, dead space. So I have ventilation, but my circulation is not that great. Heart failure, systolic dysfunction, that will do it. COPD, asthma, hyperinflation, or most often the ventilator, whoever's managing a ventilator, because you are giving too much tidal volume or you are giving too fast of a heart rate, a respiratory rate, and you are causing air travel. Effusion abnormality, interstitial lung disease, etc. And hypoventilation, nurse is putting pillow on patient's face, take the pillow out, okay, make them breathe, okay. These are the 5, 4 being important. In the ICU, if you have a saturation problem, you can only do 2 things. You can either give the FiO2, which is limited, you can't go above 100, or you can increase the PEEP, mean airway pressure, we go through the ventilator class, but for most purposes, the PEEP, okay? These are the 2 things you can change. Unless the patient has a pillow on their face, then take the pillow out, because less than 5 respiratory rate, that will be a problem because you are having a lot of carbon dioxide in your alveoli. It's a box, more carbon dioxide, less oxygen, hypoventilation, okay? But if you are breathing more than 5 times a minute, FiO2 and PEEP are the only 2 things you can change. So hemoglobin, we have a problem, right? The limit is 7, maximum 9. Saturation, we have a problem. FiO2 can only be 100%, can't do more than that. And what are you really trying to do with PEEP? What you are really trying to do with PEEP is to recruit alveoli that can be recruited and then to keep them open, okay? So in your mind, in the fantasy, you are like, okay, I know it is a heterogeneous disease, so I will use a PEEP, and the PEEP will not distend these alveoli. They will open the alveoli which can be recruited and keep them from collapsing. Very good. But in reality, some of the alveoli might not be recruitable at all. So they don't open, and the good alveoli get over-distended. So you have a shunt here and a VQ mismatch there. Therefore, that's one thing. The second thing is, what is the effect of the ventilator on your cardiac output? So if I'm in heart failure, left ventricle systolic dysfunction, I will actually get help because it reduces the preload. Okay, by increasing extra left blood comes in, it reduces the preload and it helps with contractility, and it also makes a difference because in effect the afterload is reduced because my intrathoracic pressure is high and I'm pumping away from the lungs. On the right heart, it might be different because guess what? The vessels that take blood from the right ventricle to the left side go through the same space that you are peeping shut. Okay? So it will have variable effect on your cardiac output. And therefore, ARDS tables, all of that aside, you will see that if you increase PEEP, you get some recruitment and your cardiac output and oxygenation and all that stuff will be great. But if you keep increasing it, depending on your condition, depending on patient to patient and depending same patient day to day and minute to minute, you might reach a position after which your cardiac output drops. So there is no use of increasing oxygen saturation if it ain't going anywhere. Okay? So don't just look at one number. Oh, I increased the PEEP and the saturation is 100%, right? But is it circulating? Because what we are really interested in is delivery of oxygen to tissues, not any number. Now, how much oxygen does a patient need? How much oxygen does a normal person need? What can be your PaO2? Nobody knows because you can't do that study. Okay. From ARDS-NET, we know that 88% saturation and a PaO2 of 55 is good. What happens in ECMO? What happens in ECMO? If somebody has a saturation of 80%, but my cardiac output is good and the venous return coming back is greater than 60, I'm happy. And they also survive 50%. On Mount Everest, doing femoral punctures on each other. The thing is, they had to have a conduit because I'm not taking my pants down Mount Everest, right? Okay, so I don't know how they did that, maybe on a warming tent or something. PaO2 28 and climbing Mount Everest. How does that happen? Because fit people can increase the amount of oxygen they can extract and use to 25 times what is normal at rest. You and I will be able to do 10 if somebody's running after us, I guess, in a bad situation. Okay? How much PaO2 does a mitochondria have? 1 millimeter of mercury, 1. So nobody knows what the saturation, lowest saturation is that a person can take. Okay? I'll help you figure out. But whatever you do, don't increase one number and decrease another. Because the formula is 1.34 into hemoglobin into saturation into cardiac output. So don't increase the saturation and decrease your cardiac output. It's not going to help. So you have to have that in mind all the time. That's why I wanted to make this my first lecture for you. Practically speaking, increasing the cardiac output is the most effective way of increasing your TO. Increasing the cardiac output, and you'll have this, to read later. Why? Because saturation, I'm limited to 100%. Hemoglobin, I'm limited to 9. But cardiac output, with the right preload and contractility and afterload, you can increase in multiples. Okay? So getting oxygen saturation from 80 to 88% by changing the PEEP from 5 to 15 and decreasing the cardiac output from 5 to 3, you have actually harmed the patient. And what Hippocrates said was, try to help, but in the least, please don't harm. So that is very important. Okay, increasing cardiac output. That is why whenever you do anything, you have to look at what is the effect on the cardiac output of the patient. So what about blood pressure? Because delivery of oxygen doesn't have blood pressure in it. But everybody just looks at blood pressure. So what's the problem? Why do we need blood pressure? And here comes autoregulation. Okay? It seems that, what is the normal MAP? Anybody?
65?
Nah. What's 120 by 80? Your MAP cannot be less than your diastolic, right?
85.
So it is 90 to 95 is the normal MAP. Don't try to get normal MAP. What is the scientific evidence behind 65?
The basic amount of perfusion pressure you need to get to the brain.
Somebody made it up. And once you made it up and things went okay, and you said that MAP 70 is bad, 65 is better, 80 is really bad. You know, I just said when I started the lecture, in the last 15 years, most of the development and improvement in critical care has been that less is more. Okay? So now who will do the study of 45 versus 65? But the theory, why did they choose 65? Is because there are some organs like the brain and the kidney and the cardiac muscles and all that stuff. It seems that if you decrease the pressure in order to increase in order to increase the output, it will keep dilating, but there's a limit after which your blood vessels can't auto-regulate dilate. Okay, and after that your blood flow becomes dependent. And it also seems the other way, hypertensive crisis, what is happening is your blood pressure goes up and the blood vessels keep on constricting, and then they can't. And after that, when you have that cerebral edema and headache and all that stuff from hypertensive crisis, it's because you are losing your autoregulation. And in most people, it is 50 to 150. I want to be safe because different organs might have different autoregulation. So I add 15 and I come up with 65. Okay. But whenever critical care has tried to come up with one single number for everybody, it never works. So we have a patient in the ICU. MAP is 55. Guy is eating, shouting, calling names to nurses, peeing like a racehorse, 0.8 ml per kg per hour. Capillary refill. There is a study called Andromeda shock. People don't have money like you do in the United States, right? So they compared serial lactate with capillary refill. It's the same. You could do serial lactate or you could do capillary refill, right? Because the three things that tell you that your perfusion is okay is what? Mental status, urine output, and skin. Okay, capillary refill, right? Good. So they came up with 65. Again, nobody knows, because when you do ECMO and you do VA ECMO and the patient has no cardiac output, you are okay with 60, right? On the other hand, you also know that some people have a blood pressure of 180 at home. And one of the definitions of hypotension is less than 40 systolic to what you are used to is also hypotension. So I could be 110, 120 and still be hypotensive. There is a case of aortic dissection, LVH and all that stuff, hypertensive guy, uncontrolled, came in with aortic dissection. What do? You make the heart rate less than 60 and you make the blood pressure, around 100. And that was enough to kill his kidneys. Why? He's not hypotensive, but he's hypotensive. So look at the patient and choose an MA. Because some people will do okay with 55. Not everybody. The protocols are a framework, guidelines are a framework under which we operate. If you become the protocol robot, you will have worse outcomes. People have talked about it and people have shown it because you forget to individualize your care to the patient. Okay? So MAP 65, I'm great. What's the urine output? What's the skin blue? Urine output, he has not made urine. What is his home blood pressure? Oh, he lives at 200. Maybe 65 is not for him. Okay? So you got to have that in mind all the time. So once you have an MAP goal, 60, 55, 65, okay, somewhere in that range. I would not do 50 because of the theoretical knowledge that I already have. Once I have achieved my MAP goal, all my effort is to see whether I can, how much I can increase your DO2 without harming you. So all the studies where they maximize DO2, like I'm going to maximize it, ended up with worse mortality, surgical studies in the past. The reason is that be lazy, the minimum support necessary to preserve life while the patient makes themselves better. Once I optimize the DO2, now it becomes the patient's fault. If they can increase their VO2 in response to my increased DO2, they survive. And if they can't, they die. Okay? Good. Everything I do for DO2. Okay. Now, what about DO2? In a normal person, if you circulate 1005 ml per minute of oxygen delivered to the tissues, the body uses 200 to 250. Why? So that we can run when we have to. When the tiger rushes after you, you got to run. Can you run faster than the tiger? So why do you run at all?
Hopefully you find somewhere to hide.
You don't have to run faster than the tiger, you just have to run faster than everybody else. Okay, that's the reason. Because the tiger is also lazy, not here to race. Okay, good job. So normal is so that we have a reserve, but it never increases more than 50%. Why can't we use 100% of the oxygen? Is because different organs have different needs. Okay, so your heart receives 5% of your cardiac output, but it's always working without a break. Okay, so the oxygen utilization of the whole body comes to 50%. Below that, you start seeing signs of anaerobic metabolism because things start failing. Some organs more than others. Your bones will never fail. Okay, all right. I mean, they can, but not in the ICU because of ischemia. So this is usually what I use to explain the venous oxygen utilization and saturation. Okay. So I have an open truck. That is actually my truck. I have a red truck. Okay. Ford 150. It's the best. Okay. Every day I go through the road to deliver bananas to the shopkeeper. How do I get rid of this? No. Can I get this? Oh. So every day I take 100 kgs of bananas, but by the time I reach the shopkeeper, it is 75 kgs. And we are okay with that because we know there are monkeys on the road and the monkeys eat a certain number of bananas. Okay. But one day I take my 100, but by the time I reach that, it's 60. What happened? Then I'm like, oh, I had traffic on the road, so I was driving slower than usual. The monkeys were eating their 1 banana per minute per monkey. But I was slow, they got more time. So I came with a SVO2 of 60. It's a low flow state. Or the monkeys were just more hungry because they have got septic, or they have got, like, they've got trauma. They want more, they are more hungry. Okay. When that happens, I know that the next day, I have to load with 115 because this guy needs 75 in his shop. Make sense? I'll give you an opposite example. I take my 100 banana, reach the shop, and it's 100. What happened? Either the monkeys all died, no using, or I took a bypass like I would with sepsis. You see, there was a block, so I went some other way through the city. No monkeys, no bananas getting eaten. Okay? So if you are looking at, is my DO2 good or not? Like, what do you mean optimize DO2? Like, what am I following? The best thing to follow is the oxygen extraction ratio. Now, you could also say, hey, I'll take a venous oxygen saturation, and if it is less than 60% trending towards 50, I'm going to increase the cardiac output because this is a low output state. And if it is 70, 75, then I'm good. But that assumes that your arterial saturation is limited. We had a case recently. Patient had a oxygen saturation of 80.8. Now what do you do? Is my adequate oxygen delivery adequate? So you do the venous, comes back 54. You're like, that's low. But you do the extraction ratio, saturation of oxygen minus saturation venous over saturation of oxygen. And that ratio, if it is 25%, you are great. If it is 40%, you are in trouble. If it is 50%, the lactate is getting up there. Okay? Why would capillary refill be as good as lactate? I could not understand that. Anybody have an idea? Anybody? Hello?
Lactate is a secondary measure of hypoperfusion.
Yes, because there are multiple reasons why the lactate goes up. In fact, in really bad shock states, lactate is increased not because of anaerobic metabolism alone, but because of pyruvate levels being increased and the fact that under adrenergic, hyperadrenergic states, it is the preferred fuel for the cardiac myocytes. Am I getting that right?
For the most part, yeah. Again, you think of lactate as a marker of metabolic stress and not hypoperfusion, right? Because most of the time it's not hypoperfusion, right? Olympic rowers, their lactate is, at the end of their thing, their lactate is in the upper 20s, right? Nearly 30, right? They are not hypoperfused, right? It has nothing to do with that, right? Again, if you give somebody epinephrine, it raises their lactate level because you get non-enzymatic release of lactate from muscle from beta-2 stimulation, right? So a high lactate doesn't mean that you're either, number one, hypoxic or anaerobic. It can be, but most of the time it isn't. It's better thought of as a marker of metabolic stress.
Right? So that is why also don't just concentrate on one number. Right? Look at the whole picture. Look at the whole picture. The patient with hypovolemic shock who came in with a BNP of 3000 is an example. Look at the picture, because if you look at the BNP, your mind will tell you to give Lasix. Don't. Good. Oh, it's here. So, yes, if your oxygen saturation is 88 or above, you can use SpO2, but it is better to use oxygen extraction ratio. And if it is getting greater than 30%, we need to investigate. And if it is greater than 40%, do something about it. Okay. And the reason is that the SpO2 is a very, so that's another example. See, the River et al. Study that was big when I was a kid, but it's not that big now. I was a resident when it sort of came out or something, or must have done a few years before that. 2003, you do. What is it?
What study are you talking about?
Rivers et al.
Oh, that was in the 90s.
Late 90s,
Late
something,
90s,
right?
yeah.
So the thing is that they used an SpO2 of 70%, MAP of 65. In human beings, any study that uses one number, like one number for everything, SpO2 70, how did they fail? Because it is better to look at oxygen extraction ratio. Because one number curing everything almost never works. Okay. So in critical care, especially the more sicker the patient is, I'm thinking in terms of DO2 and optimizing DO2, the whole picture, not just saturation, not just blood pressure, the whole picture. That formula never leaves my mind. Okay. Any questions?